When you look at site of care optimization opportunities, we break it down into two different buckets, if you will. The infusions that are primarily treating chemotherapy, for cancer, and non-chemotherapy infusions. So these are the drugs like Remicade for the autoimmune diseases, or immunoglobulin and Tysabri for multiple sclerosis. We break it down because the approach to solve that site of care problem is typically different by those types of drugs that are administered because of the different specialties that are prescribing those drugs. Oncologists in increasing numbers are being purchased by hospital practices, and when that occurs, there's an incentive for those oncologists to continue to infuse or to begin infusing in the hospital site of service. So it's more of a political challenge in changing that physician, who's now owned by the hospital, to convince them to have the patient serviced at a different site of care. There's minimal clinical reasons why most chemotherapy can't be done in an alternate treatment site, but there's a lot of political reasons why it can't be done. On the non-chemo space, while there's definitely political things that we encounter, it's not near the degree that you see on the chemotherapy side. You tend to have still more independent practitioners who aren't owned by the hospital on the non-chemo side. And keep them, think about it like this. If you have a rheumatologist or gastroenterologist that's prescribing Remicade, and they're referring the patient to the outpatient hospital because they don't want to do it in their office, they're not going to lose any revenue by referring that patient to home infusion. Right, so they're much more willing to work with us, as opposed to if that doctor was being either directly reimbursed for the drug or being incented by their hospital employer to refer that patient to the hospital. It's a much easier discussion to have with the physician.